Early repolarization syndrome is an ECG pattern with concave upwards ST elevation and sometimes a notch at the J point known as J wave. For a long period of time, this was considered as a benign condition without any significance, just as a normal variant. Later, some publications linked early repolarization syndrome with idiopathic ventricular fibrillation. Some reports even considered it as part of the J-wave syndromes. This is the J-wave, which could include very dangerous arrhythmic disorders like Brugada syndrome. So there was a lot of discussion going on about early repolarization syndrome, whether it is benign or malignant. In this case, you can see ST elevation in V2, V3, V4, V5 and V6 with J waves, and it is there in lead 1. AVL it is not very significant. Inferior leads also there is no ST elevation, mainly confined to lateral but extending up to V2. This is another ECG with early repolarization syndrome, V2 to V6, and probably a little bit in lead 1. Here, additional feature is that the T waves are quite tall and ST is upsloping. This may be mistaken for hyperacute phase of myocardial infarction if the person happens to present with chest pain. On the other way around, person with early repolarization syndrome is not immune from myocardial infarction, so don't dismiss the case as just early repolarization. Look at other clinical features, and if necessary, echo and cardiac enzymes will tell you whether it is associated with acute myocardial infarction. In the ECGs which are shown, you may have noted that the heart rate was relatively low, below 60 or so. Early repolarization pattern can disappear when the heart rate increases with mild exercise like walking or with atropine, and sometimes even with administration of potassium. But these are not to be tried when the person presents with symptoms suggestive of acute myocardial infarction. Because of the wide variation in the risk of those with early repolarization pattern and J-wave syndromes, an attempt has been made to risk stratify by Charles Antzelevitch and associates, and that is given here. Type 1 pattern, which is predominantly in lateral leads, prevalent in healthy male athletes. That's the type which we often see, not even in athletes, even other healthy, very active males. Type 2 pattern is riskier, predominantly in inferior and infralateral. The number of leads are increasing with a higher level of risk. Type 3 is the maximum risk, which is having global ERPS pattern in inferior lateral and right precordial leads. They can develop malignant arrhythmias and ventricular fibrillation storms. An electrical storm is defined as 3 or more episodes in 24 hours. So this risk stratification may be useful in evaluating a person with ECG showing early repolarization pattern or early repolarization syndrome, sometimes called as part of the J-wave syndromes. And those with that notch at the J point or slurring at the J point are also supposed to have slightly higher risk.